All right, my disclosures are listed in the booklet. So today I'm actually going to be focusing predominantly on other molecular events in adenocarcinoma beyond EGFR, and Sal will focus on the EGFR. As you can see, we have about half of the pie chart of oncologic drivers characterized, at least on this fairly recent schema. Many of us in clinical practice are already obtaining the status of our patients for KRAS, EGFR, and EML4 ALK, and ROS1 has come up a few times, which is actually not here, but has an incidence of about 1% in lung cancers. There are, however, other molecular events, either mutations or translocations, or in this case, MET amplification, which are also not that common and which currently we may not be appreciating in our routine clinical practice, since these are not on the guidelines to test for and not part of many routine assays. And just out of curiosity, in your practices, how many would be obtaining data on some of the more rare events beyond, I guess, at least the big three from your initially diagnosed patients? Which is really no one. So this really portends more of hopefully how we can use this information in the future. So today I'm going to focus on ALK translocations, clinical trials for KRAS, ROS1 data, and then also briefly I'll touch upon some emerging data in BRAF, RET translocations, and MET. And in the interest of time, I can't review everything in depth, but at least hope to touch upon some main points. So first, the EML4 ALK fusion. EML4 is the most common partner seen with ALK fusion, and this occurs in about 3 to 5, and some reports say 7% of lung cancers. As you can see here, our standard FDA-approved assay to diagnose an ALK rearrangement is a FISH break-apart assay. And in this assay, a probe recognizes the 3' and the 5' end of the ALK gene, and in cases where there is a translocation event, there is a split signal, which is positive if it's detected in over 15% of cells. There are other assays which can potentially pick up an ALK translocation, including some of the next generation sequencing platforms, but the current one that's FDA approved is the FISH. So current ALK inhibitors include Crizotinib and Ceritinib, both of which are FDA approved. Alectinib, which has breakthrough designation by the FDA and currently is available in expanded treatment protocols. And then also AP26113, as well as some an up-and-coming ALK inhibitor, X396. So Crizotinib was the first ALK inhibitor to obtain approval. This was initially developed as a MET and ALK inhibitor, and when it was noted that it had activity against ALK, the phase 1 study was enriched for a population of ALK translocated patients. And in this trial, the response rate was impressive 57%, with actually very immediate clinical responses amongst patients who were responding. At the time, the 8-week disease control rate was 87%, and this radiograph illustrates some of the responses that were seen with single-agent Crizotinib in this population. It was compared in a randomized trial to second-line chemotherapy, which was either pemetrexed or docetaxel at the discretion of the treating physician. And as you can see, there was improvement in progression-free survival with Crizotinib in the second-line setting, a trend that perhaps pemetrexed had some improvement in PFS compared to docetaxel, but again, it wasn't really powered to look for those differences. And the response rate also favored Crizotinib at 65% versus 20% for chemotherapy. I should mention that there is also first-line data now with Crizotinib compared to chemotherapy, which also shows an improvement in survival and response rates. So not surprisingly, this has moved into the first-line option for these patients if it's known that they have an ALK translocation. Unfortunately, they all eventually develop progression around a median time of around 8 months. And this, about 50% of the progression events can occur in the CNS, but systemic progression is possible as well. And so there was a great need to look at other agents to study in this situation. Another point to consider is also the type of progression. Many patients, up until there was the availability of second-generation agents, if they had what we would call oligo progression, would often get local treatments and then continue with Crizotinib. And I think many of us still do this in certain situations. However, now there are other systemic agents which could be utilized instead in this setting. So Ceritinib, or LDK378, in preclinical assays was shown to have potent activity against ALK. It had much less activity against c-Met and differs from Crizotinib in that. And in xenograft studies, you can see had a very durable response compared to Crizotinib and also resistant populations. So the phase 1 study with for Ceritinib established the dose to be 750 milligrams once a day. This is still taken on an empty stomach, and the food effects studies for this agent are still ongoing, and so currently the data we have is really fasting. There is thought that there is some food effect, and so it's generally not recommended to take it with at least meals, or especially heavy meals. In the expansion phase on this trial, 255 patients with ALK-positive lung cancers tumors were treated. 246 of them had lung cancers. Majority had received a prior ALK inhibitor, and for the majority of those patients, it was Crizotinib. About 83 were ALK inhibitor naive. This just shows the demographics of patients on this study, and majority actually had fairly good performance status. There was both smokers and former or current smokers accounted for about a third of the patients. And what's also notable is that, at least in this phase 1 trial, this was a more heavily pretreated population, with about 43% of patients having had at least 3 prior treatments. Not surprisingly, they were all adenocarcinomas. We would not really expect to see this translocation event in squamous cell. The response rates noted amongst the entire population on this trial was 57%, with a suggestion that perhaps it was slightly higher at 65% amongst the ALK inhibitor naive population. And as you see from the waterfall plot, there was activity seen in both the prior treated and the naive population. And this illustrates that as well. There's now more mature data regarding the duration of response, especially amongst the ALK inhibitor naive population, which does seem to be improved even compared to the previously treated population. And similarly, the PFS also was higher, with now the latest report which was reported at ESMO was a median PFS of about 18 months in the ALK inhibitor naive population. In the pre-treated population, it was 8.2 months, and in all of them it was 8.2 months, and in the pre-treated it was 6.9 months. And knowing the predisposition of these patients to have brain metastases. It's important to note that many of the second-generation inhibitors do have CNS penetration. A small subset analysis was done of patients on the phase 1 study. Those who had measurable disease had very small numbers, and so it was difficult to get a robust data set, but at least from the small numbers, it was clear that there was activity. The trials, many of them had allowed patients to be enrolled if they had a history of untreated brain metastases as long as they were asymptomatic, and so it provided an opportunity to evaluate the activity of agents in this setting. And here also the intracranial response rate, while was small patient numbers, you can see there was some evidence of response. So resistance is seen with the second-generation inhibitors as well. And more emerging data is coming regarding what secondary mutations are seen in this population. On the patients who were on the phase 1 study, many, or not many, but some were able to have mutation testing done before being placed on the trial. And as you can see, activity was seen regardless of mutation status, and it was seen both wild type as well as in some of the acquired mutations. The 1196M is considered to be the gatekeeper mutation, but also Crizotinib had activity in this population. So AP26113 is another second-generation inhibitor in development. This also has activity against EGFR, and so trials have included ROS1 and EGFR patients. Focused on the ALK subset today. This just illustrates the patient characteristics, which again included about 71 patients who had a history of a prior ALK inhibitor, and at least half of the patients had at least 2 regimens of therapy, if not more. There was clinical activity seen, and this is actually, I think, a patient of Corey's who was on treatment with this agent. And the waterfall plot illustrates this as well, with many patients having a partial response and 1 complete response. Overall, the response rates, there was a 72% objective response rate and 69% post-Crizotinib, with a median PFS of 10.9 months. And I guess this would be the swimmer's plot, which shows the time on treatment, which for some patients was quite durable. And CNS penetration was noted with this agent as well. 9 out of 13 patients had regression of brain metastases, and improvement in leptomeningeal disease was observed in 1 patient. Moving on to alectinib, as I mentioned, this also is currently available in expanded treatment protocols, and the sense is it's probably the next one that would be available for approval at some point. As you can see, it is also a potent ALK inhibitor, in addition against the 1196 mutation subset, and the xenograft studies have illustrated this as well, where animals treated with xenografts with alectinib had a durable response. This is a waterfall plot from a Japanese phase 2 study with treatment-naive patients, and these patients who were enrolled on this trial were either ALK positive by FISH and immunohistochemistry. The response rate was an impressive 93%, and this agent is actually now approved in Japan. Again, CNS activity was noted. And some of the patients had a prior history of radiation, but even in patients who did not have prior radiation, CNS activity was noted. And this is radiographs to illustrate that. At the Chicago lung meeting, an update was provided on this trial. One interesting factor is that the dose in the Japanese population is different from the dose that was established in North America, as you'll see. About 40% of these patients were former smokers. As I mentioned, the response rate was 93.5%. And in this population, the 2-year overall survival was almost 80% with a PFS of 27 months. So overall, very impressive data, but I think we have to have some caution that this represents a different population than many of us see here in North America. Toxicities that were reported on this trial included interstitial pneumonitis in one patient. Visual disorders were rare, but most of adverse events were grade 1 or 2, and the common ones were rash, increased in the transaminitis, and very mild GI toxicity. Now, the North American data set with the phase 1-2 trial was reported in Lancet Oncology. And in this study, 47 patients were treated. As I mentioned, the MTD was 600 milligrams BID. The response rate in this population was 55%. 21 patients had CNS metastases, and the CNS response rate was 52%. X396 is another ALK inhibitor, which is currently in investigation in earlier stages. Lena Horn had reported at the Chicago meeting a phase 1-2 trial in which 41 patients were treated. 18 had prior Crizotinib and 2 had prior Ceritinib. And dose-limiting toxicities that were noted included fluid overload and rash. Common grade 1-2 toxicities were rash, diarrhea, vomiting, and fatigue. And in the 17 evaluable patients, the partial response rate was 59%, with 12% having stable disease. I think as these newer agents are emerging, it'll be an interesting thing to evaluate will be the activity in patients who have now had at least 2 prior ALK inhibitors, since these are, the patients that many of us are going to be having in our practices with 2 approved agents. Just briefly on toxicity, I listed the common ones seen with these agents. Crizotinib, I think many of us have the experience that it's fairly well tolerated. There is mild grade 1-2 nausea and diarrhea, but usually this is something that can be managed. The Ceritinib, one of the notable toxicity features, which was appreciated in the phase 1, is a higher incidence of grade 1-2 nausea and diarrhea, up to 76 to 80%. One thing to keep in mind is that Crizotinib can be dosed with a light meal or snack, and when that was initiated, many noted that the toxicity profile, at least the GI toxicity, improved. And currently, since Ceritinib is given fasting, we really can't appreciate if the food effect would ameliorate some of the toxicities. As there's more food effect data, I think this will be interesting to look at. The other notable toxicities are increase in LFTs, and these patients do need to be checked periodically to see if they have a transaminitis. On the trials, if they went up to a grade 3, treatment was held until they resolved and dose reductions were done. It doesn't necessarily always happen when treatment's initiated. Sometimes somebody can be on these agents for some time and then develop a transaminitis at a later course. And pneumonitis is a rare event, but has been seen with Crizotinib and Ceritinib. And so especially if someone has worsening respiratory symptoms, it's important to consider to see if there could be a drug-induced pneumonitis, which would respond to steroids. I did not go too much into the pulmonary toxicities with AP26113. I would just mention that its development has been a notable factor in its development is in some patients there was a sudden onset of acute pulmonary toxicities, which seems to have improved at lower doses, but it's in contrast to the pneumonitis seen with some of the other agents. And this is just to remind myself that dose reductions can be done with all of these agents. In the phase 1 trial with Ceritinib, 60% of patients had at least one dose reduction, and oftentimes toxicity can resolve or at least improve with that. And this is just an overview of current data. As I mentioned in the first line study with Crizotinib, the PFS with Crizotinib is 10.9 months. It's in contrast to 7 months with chemotherapy on that trial. In the second line setting, it has been 7.2 months. Similarly with Ceritinib, the PFS has ranged from 7 to 9 months in the prior treated population, but does seem to be higher in the naive population. And we obviously are awaiting more mature data regarding PFS in all of these populations. Moving on quickly now to KRAS. This just to illustrate the pathway associated with KRAS. Many attempts to target this mutation have really focused more on downstream targets, including MEK, and there are multiple MEK inhibitors in development, not just in lung cancer. Selumetinib is one that was studied in a phase 1 trial, and this showed that selumetinib plus docetaxel was manageable. Preclinically, there seemed to be increased tumor regression in a KRAS mutant cancer model, and that prompted more interest in a clinical investigation in this particular population. This study by Pasiani was specifically for confirmed KRAS mutant tumors, and they were randomized to either selumetinib plus docetaxel versus placebo plus docetaxel. And as you can see, the overall survival favored the combination at 9.4 months versus 5.2 months. And similarly, the PFS also favored the combination. Response rates were also higher in the patients who received selumetinib plus docetaxel, approaching 37%. And so just to summarize other studies that have been done with MEK inhibitors in KRAS mutant populations, this is the one that I just provided the data on, which is worthy of further investigation. Trametinib is another agent that's been studied with docetaxel, and that combination in a small trial had a response rate of 28%. There's also a study of trametinib plus pemetrexed with a response rate of 17% and a PFS of 4.1 months. There have been trials with selumetinib plus erlotinib, but overall activity seems low with that combination. And again, trametinib plus docetaxel has also been investigated in small trials. But the response rates overall, or rather versus docetaxel, but the response rates were similar in either monotherapy. ROS1 is another translocation event seen rarely in lung cancers, and it's been mentioned a few times here already. Crizotinib has activity against ROS1 as well, and in a 50-patient cohort had a response rate of 72%, which was durable. Duration of response median was 17.6 months, and the PFS was 19.2 months. And so based on this data, I think crizotinib is oftentimes covered depending on the insurance provider, and is certainly an option for these patients if a trial is not available. BRAF mutations is another rare event, but given the presence of BRAF inhibitors worthy of study, Dabrafenib has been one particular agent that's been studied in this population, but there are others. And as you can see, the responses were noted in BRAF mutated lung cancers to Dabrafenib. RET translocation is another rare event. The more common partner that's been characterized in lung cancer adenocarcinomas has been KIF5. And so there are trials ongoing to look at the activity of RET inhibitors in this population. Alex Drolon had published a case report of 3 patients that were treated at Memorial in their response to cabozantinib, and as you can see, there is at least anecdotally clinical activity, and he's actually conducting a clinical trial now with this agent specifically for these patients. And then finally, MET. There have been many MET inhibitors that have been investigated. It's been somewhat challenged by trying to determine the best biomarker to select patients for these types of agents. Trials in the past have looked at immunohistochemistry and H scores, and I think in that setting, there seems to be less activity. However, there has been more interest in MET amplifications. And in this cohort of the Crizotinib study, as you can see, there was activity with Crizotinib against the more intermediate and high MET amplified patients. And other agents are also looking at this particular subset of lung cancers. And in the interest of time, I haven't even brought up MET mutations, but perhaps that's something for next year.